Good afternoon, guys. I have discussion A for you. We are discussing gut inflammation can primarily alter the enteric nervous system, which is, quote, the second brain. Okay, so give me a minute to set up for the show, and we will dig into the topic of today's discussion A. Give me a second, please. Okay, here we go. Gut inflammation can primarily alter the enteric nervous system, the second brain, leading to long-lasting mortality problems such as IBS-like symptoms. What the research shows. Multiple recent studies reveal a clear mechanism linking gastral inflammation such as that seen in inflammatory bowel disease or IBD to lasting structural and functional changes in the enteric nervous system. ENS, the vast neural network that controls digestion. Key findings include inflammation activates enteric neurons, causing them to release signals like the chemokine or CCL2 that attract monocytes into the gut's neural plexus. These monocytes then differentiate into microphages, which normally help with repair, but in excess remodel the ENS in harmful ways. This remodeling leads to disorganized nerve circuits and uncoordinated intestinal muscle contractions, producing mortality disorders even after inflammation has clinically resolved. The results: persistent symptoms such as abdominal pain, altered bowel habits, and IBS-like dysfunction in patients who appear to be in remission. Why these changes last. The ENS, sometimes called the second brain, because it contains over 100 million neurons and operates semi-independently. When inflammation disrupts its architecture, the system doesn't always return to normal, even after the immune flare subsides. Researchers found neuronal loss and aberrant neurogenesis occurring during inflammation, reshaping gut neural circuits. Hypoxia, which is low oxygen during inflammation, triggers a protective stress response in neurons via HIF1A, which can limit damage. But only if activated early. If this protective pathway fails or is overwhelmed, long-term mortality dysfunction becomes more likely. Why this matters for patients. Even with modern treatments that control inflammation, up to half of IBD patients continue to experience GI symptoms during remission. The new findings explain why the inflammation may have already rewired the ENS, leaving behind a functional disorder. This helps clarify why some patients develop IBS after an inflammatory episode, why symptoms persist despite normal colonoscopy or lab results, why early aggressive control of inflammation may prevent chronic mortality problems. Emerging therapeutic insights. The research highlights potential new strategies boosting the HIF1A mediated stress response early in inflammation may protect ENS structure. Targeting neuroimmune interactions, not just inflammation, could become a future treatment avenue. Understanding ENS remodeling may also inform therapies of other chronic gut-brain axis disorders. Gut inflammation can cause lasting structural and functional changes in the enteric nervous system, the second brain, producing persistent motility problems, such as IBS-like symptoms, even after visible inflammation has resolved. Key findings: recent preclinical and translational studies show that intestinal inflammation activates enteric neurons, which then recruit circulating monocytes that enter the enteric nervous system and differentiate into macrophages, and in excess of these immune cells remodels neural circuits and disrupts coordinated muscle contractions. Explains why patients with prior inflammatory flares can develop long-term motility dysfunction. Important experimental details: neuronal activation during inflammation increases chemokine signaling, e.g., CCL2, that attracts monocytes. Macrophage accumulation within enteric granula drives structural reorganization and loss of normal circuit function, producing uncoordinated paralysis. Hypoxia during severe inflammation triggers a neuronal stress response, HIF1A pathway, that can be protective if engaged early. Failure of this response increases risk of permanent dysfunction. Clinical implications: many patients with IBD continue to report GI symptoms during remission. ENS remodeling provides a pursuable biological basis for those persistent symptoms and for the development of post-inflammatory IBS. Standard inflammation markers and endoscopy can appear normal, while ENS architecture and function remain altered. So symptom persistence does not always indicate active mucosa. Emerging therapeutic directions. Early aggressive control of inflammation may reduce the chance of ENS remodeling and long-term mortality problems. Targeting neuroimmune interactions. For example, limiting monocytes recurrent to enteric ganglia or modulating macrophages behavior is a promising research avenue. Enhancing protective neuronal stress response. H1 or HIF1A mediated pathways during acute flares could preserve ENS structure. This is currently experimental. Limitations and uncertainties. Most mechanics data from animal and preclinical models, while human tissue studies corroborate some pathways. Translation to safe effective therapies will require clinical trials. Not all patients with prior inflammation develop persistent mortality disorders. Genetic, microbiome, and environmental factors like influence susceptibility, but these modifiers are not yet fully defined. Practical takeaways for patients and clinicians. Persistent GI problems after IBD remission may reflect ENS remodeling rather than active inflammation. Consider functional testing and multidisciplinary management. Gastroenterology, mortality specialists, dietitians, and pain specialists. Early control of flares and research participation, when available, may offer the best chance to prevent long-term ENS damage. Okay, guys, that's A for you. I will be back on with B shortly. Give me a few minutes, please, and I'll be back on with B for you. For now, Gator Wellness. Take care, folks.